welcome to the MedEClasses postgraduate lecture series. We'll be focusing today on a very important, although a rare but complicated topic of hypercalcemia. We had this 3-year-old boy who presented with bone pain and had found to have a high level of calcium where the phosphorus was on the normal level. Now, when I discuss about the pathophysiology, we'll understand that calcium and phosphorus, both of them we have to assess in a proper fashion to achieve a right diagnosis in that perspective. Now, on evaluation, first step you always look at is the PTH level. Now, there the PTH level was low, which was in a way indicated by the phosphorus level, which was normal, because if your PTH is high, you expect the phosphorus level to be on the lower side. So this was a PTH independent form of hypercalcemia. The vitamin D level was found to be normal and calcitriol level was also normal, excluding a vitamin D form. So often we consider, okay, when you have hypercalcemia, you either have a PTH or a vitamin D related cause. Both these causes have been excluded in this scenario. So what we are looking at is a rare scenario. And what was found that there was a lytic lesion which was present in this scenario, which resulted in the diagnosis of a lymphoreticular malignancy, leukemia. So hypercalcemia, though usually endocrine, may also have significant component of other disorders which we have to be aware about, and that's why we need to be cautious about. So over the next hour or so, we're going to focus about the practical aspects of pathophysiology of hypercalcemia, evaluation, management, and case-based assessment. All of you are welcome to go to our website, learning.growsociety.in, which has got a lot of resources with regards to pediatric endocrinology, including a lot of training opportunities which are there. We have got our YouTube channel, which has got a lot of information, along with validated courses on different aspects of pediatric endocrinology, including fellowship programs and the postgraduate programs which are available. We do frequent grand rounds along with the approaches and postgraduate lecture series which we are doing today. There are publications and mobile applications which can be used for day-to-day care. The key questions to look at in this setting is it really hypercalcemia? What is the particular site and what is the individual cause to identify the diagnosis and management? So hypercalcemia basically will have multiple manifestations as calcium affects different parts of the body. It affects the bone strength, neurotransmitter stability and nerve function, cardiac contractility and conduction, release of enzymes. If your calcium levels go up, you will have release of more enzymes, which may result in a pancreatitis-like situation. It is also known to induce a ADH resistance, causing a nephrogenic DI situation and the gut motility. So if your calcium levels are going high because of hyperparathyroidism, you will have increased bone resorption, resulting in reduced bone mass. You may have encephalopathy with a very high level of calcium. There would be hypertension and ECG changes which are there in the cardiac system. You will have pancreatitis, which may be the classical manifestations. Polyuria, dehydration are more common in the setting of acute hypercalcemia, and this is a common presentation, as well as constipation. So these are the findings which may be there. Now, manifestations will depend upon the specific levels of calcium. Typically, till around 12 milligram per DL or 3 millimoles per liter, you will not have any symptoms. Till around 14, the symptoms of irritability will come up. Polyuria starts after 12, and that's a significant one, along with hypertension. Typically, if you talk about acute presentation of hypercalcemia, you are dealing with severe dehydration. That's typically around 15, 16 levels of calcium. And then you have encephalopathy and seizures. So levels of calcium and the rate of rise of calcium makes it more likely about what sort of presentation we are dealing with. Neonates, often we will miss calcium unless we are measuring it. So if you have any neonate who has unexplained dehydration, polyuria, hypotonia or altered sensorium, when you're measuring sodium, when you're measuring potassium and your glucose, these are normal, get a calcium level checked also, because this could be the rare case of neonatal severe hyperparathyroidism, which may have huge implications on that regards. Children presentation and older presentation is different. We all talk about bone pain, abdominal pain, groin, and all those things which are there, a common manifestation. So abdominal pain and dehydration, unexplained hypertension, renal calcification. This is a common one. You get the renal calcification, then you check calcium and you find it to be high. And of course, if there is an unexplained metabolic bone disease, you will get that from that regards. Once you have these features, you will assess for calcium, which should ideally be done in a fasting sample, and it may have an issue in terms of albumin levels. If they are high or the protein levels are high, you will have pseudo hypercalcemia, and you can always correct that for the correction of albumin, which you have discussed earlier. So for every gram per DL increase in albumin, you have to add 0.8 to get the right calcium in that regards. There are specific criteria and cutoffs which are there for hypercalcemia. Neonates tend to have a lower cutoff. Post-neonatal period, you get a cutoff of around 12 milligram per DL, typically when you start getting worried. Now, once you have documented hypercalcemia, the next issue is the site. And the most important investigation in anybody with calcium disorders, be it rickets, be it hypocalcemia, be it hypercalcemia, is phosphorus. In the setting of hypercalcemia, if the phosphorus level is low, you are dealing with a PTH related cause, which is increasing calcium and decreasing phosphorus. And if it's high, it's a vitamin D related cause. Urinary calcium, again, you expect anybody with hypercalcemia to have a high urinary calcium. If your urinary calcium is on the lower side, you're dealing with a calcium sensing receptor defect. Always in the newborn period, get a family screening done for both mother and father to look for familial hypocalciuric hypercalcemia or familial benign hypercalcemia. Especially also look for maternal hypocalcemia. As we discussed, maternal hypoparathyroidism or long-standing maternal vitamin D deficiency causing hypocalcemia will cause the reverse scenario, like infant or diabetic mother has hypoglycemia. Here you will have hypercalcemia, which is transient. Alkaline phosphatase levels are expected to be high in individuals with increased bone resorption. If the ALP level is low, think of hypophosphatasia as a cause. Now, once you have a basic classification, you go for the confirmatory workup, look for PTH. Now, everybody whose calcium is high, you expect the PTH level to be low. A high or a normal PTH, a PTH level more than 20 in an individual with hypercalcemia suggests the diagnosis of a primary hyperparathyroidism, which is important. So it has to be a contextual scenario. If it's less than 20, then you can think of a PTH independent cause. Vitamin D level, of course, if your phosphorus is high and your PTH is normal or below 20, you do a vitamin D level, you will get it high in toxicity. Calcitriol level, if your vitamin D is normal, then you get at calcitriol levels. This will suggest a granulomatous disease like fat necrosis or other scenarios. And in very rare scenario, would you like to do a PTH related peptide? That will be in situations wherein you will have a neoplastic scenario, which can cause that. As discussed, always interpret the PTH level with regards to your calcium level. If your calcium is high and your PTH is high, it is of course hyperparathyroidism. And if your PTH is normal, it will be a problem in terms of a calcium sensing receptor defect. So this is something important. So the level of elevation of PTH is lower in a calcium sensing receptor defect as against the hyperparathyroidism. Remember that the high levels of PTH you see in the setting of secondary hyperparathyroidism like 200, 300 are rare in scenarios of primary hyperparathyroidism. If you have PTH in hundreds and you have hypercalcemia in an older individual, think of a parathyroid malignancy. That's a strong possibility to think of. Typically, the PTH is not very high. It will be like 50, 60, under 100 in that scenario. But any PTH about 20 with a high calcium is significant in that scenario. So hyperparathyroidism basically means you have hypercalcemia with hypophosphatemia and you've excluded all causes of secondary hyperparathyroidism, normal creatinine, because if you have long-standing renal disease, you may have a tertiary hyperparathyroidism, normal vitamin D, and you have excluded hypophosphatemic rickets as a cause. Now, once you have diagnosed hyperparathyroidism, whether you need to do a localization study, so for that you do is you basically decide about whether you want a solitary lesion and plan for surgery. So there is a SESTA maybe scan, which basically looks at a differential between the thallium and technetium. That differential can also give you the localization of parathyroid. In children and in adults below 30 to 40 years of age, we do not rely based upon the scan findings to decide about the surgery. Because as I said, the likelihood of a multifocal lesion is more. The likelihood of a genetic cause is more. The likelihood of recurrence following removal of an adenoma is more in this setting. And if you have a single highly functional lesion, it will take up all the scan. And the other small areas may not be active in that regards. Once you remove this big area, you will have development in the other areas, which will then start developing in that regards. So scan typically after infancy and in family history you may consider. So technetium, maybe scan and subtraction study, as I discussed, will give you the diagnosis. So now if you look at the classification, we mainly look at hyperparathyroidism and calcium sensing receptor defect as common causes, as would be the granulomatous diseases and vitamin D excess. So as I discussed, if your PTH is high, you're dealing with a vitamin D related cause or a bone resorption related cause. If PTH is low, you're dealing with more of a parathyroid excess in that scenario. And the phosphorus level will give you a clue also in that regard. So PTH, if your PTH is more than 20, you are dealing with hyperparathyroidism in that regards. Everybody with hypercalcemia should have hypercalciuria. If you have hypocalciuria, think of a calcium sensing receptor defect, and other parameters will also give you a clue in terms of your alkaline phosphatase levels, which will be very low in the setting of hypophosphatasia, and you will get the diagnosis, and of course vitamin D levels, which will give you a clue. So the most important investigation here is the phosphorus, followed by PTH and vitamin D, and then you decide about your further workup in that regards. So to approach a patient with hypercalcemia, the first step is to exclude common causes like hypophosphatemia or decreased phosphorus exposure in a preterm neonate who is on TPN. Drugs like lithium, thiazide, which you have to exclude, immobilization in the setting of cerebral palsy, and look at PTH levels. If your PTH levels are above 20, which I discussed suggest hyperparathyroidism, look at urinary excretion of calcium. If your urinary excretion of calcium is less, so you have hypercalcemia, high PTH, but hypocalciuria, you have calcium sensing receptor defect, you will find the magnesium level also to be high. Typically, hypercalcemia here will be mild. While if you have increased urinary calcium excretion, it's more likely to be hyperparathyroidism. In certain scenarios, like vitamin D deficiency, this hypercalciuria may be masked. So before making a diagnosis of calcium sensing receptor defect, if you check that your vitamin D levels are low, it may be better to give a course of vitamin D and see whether the urinary calcium is going up or not to identify the diagnosis. On the other hand, if your PTH is below 20, you should look at the vitamin D level. If vitamin D levels are high, it's typically a iatrogenic excess in most cases. If it's normal, look at calcitriol. If calcitriol is high, think of a granulomatous disease like sarcoidosis, tuberculosis, lymphoma, or if you're talking about a neonate, you're looking at fat necrosis as a possibility. While if it's low normal, it's mainly an issue about bone formation or increased bone resorption. Think of a malignancy, think of hypophosphatasia, the rare cause, or think of a lymphoreticular malignancy, which we discussed in the first case scenario wherein you can have that situation. So just to summarize, the most important thing here is to, of course, look at the phosphorus level followed by the PTH level, which will give you the diagnosis. So we'll go through a few cases. 12-year-old girl with irritability, dehydration, and calcium is 18. So we are dealing with a very severe form of hypercalcemia. PTH level is on the higher side. So this looks like a primary hyperparathyroidism. What do you think, Dr. Dhwani, in this case?
So because this is a neonate, one will have to look at the parents' calcium PTH status.
So you will look at the maternal and father's calcium and urinary calcium excretion, which becomes important. So here there is a relative hypocalciuria for the newborn. You expect at this level of calcium of 18 that the urinary calcium level should be much higher. So there's a relative hypocalciuria. Parents also have high calcium and low urinary calcium. So we are dealing with what form? So this is the neonatal severe hyperparathyroidism. There is either a homozygous or a compound heterozygous severe form of calcium sensing receptor inactivating mutation would require surgical intervention. 8-year-old boy with abdominal pain, Dr. Alapan, calcium is 13, phosphorus is on the lower side, PTH is 80. So what are you thinking about? Is this a PTH dependent or a PTH independent cause? PTH independent, but PTH is 80. PTH dependent cause. So now in this scenario, he was planned for surgery, but when you did the urinary excretion, it was found to be low. So what it suggests basically is that this is probably related to a calcium sensing receptor defect rather than a primary hyperparathyroidism. So magnesium here was also on the higher side, suggesting a calcium sensing receptor defect. So in somebody who is identified as a asymptomatic or mildly symptomatic individual with not very high levels of calcium, look at magnesium and look at urinary calcium before you make a real diagnosis in that perspective. And here you can use cinacalcet, which is a calcimimetic, which will basically decrease the effect, which will have an effect on the calcium sensing receptor, which will become more in that regards. 4-day-old boy with seizures, birth weight was 3.2 with asphyxia, calcium is 18, very high, phosphorus is 4.2. So how do you assess this sort of a relation of this calcium and phosphorus?
So here we, as you can see, the calcium is also high, the phosphorus is also on the higher side. So this looks like a vitamin D related cause. We do not expect an excess at day 4 of life so soon. So in the setting of birth asphyxia, one must look for purple violaceous nodules or
yeah. So important point here is that phosphorus is not low, making PTH dependent cause less likely. In this regards, PTH, of course, we will do. It was low. Then there was vitamin D level was low, but normal, but calcitriol was very high, and he had a violaceous nodule suggestive of fat necrosis. So again, in a newborn period, if you have hypercalcemia, look for skin nodules which can cause this granulomatous changes which are there. 15-day-old girl, preterm, 28 weeks of gestation, calcium is high, phosphorus is low. Is it PTH dependent cause? So you would expect the PTH to be high in this case. But there is a setting. This is a preterm child. So you have to start thinking of something else also in that. So PTH is 0. So it is not PTH dependent, but still you have low phosphorus and high calcium. So what are the possibility now? Dhwani had so nicely talked about this pathophysiology that if you have hypophosphatemia, you will have increased 1-alpha hydroxylase action, and this will result in increased calcitriol level, causing hypercalcemia in that setting. So this is because of prolonged TPN and phosphorus deficiency. It's not a PTH dependent cause. 10-year-old boy with routine workup, calcium is 10.1 and phosphorus is 2.2. Now PTH is 90. In this scenario, fractional excretion of calcium is 1.2%. So it's a borderline scenario. So this is a common presentation wherein the doubt is whether this is a familial benign hypercalcemia, because that's why you have got this mildish level of calcium elevation or nearly normal, and your urinary calcium is also slightly high, or is it truly a hyperparathyroidism? Because of vitamin D deficiency, this is being masked. So how will you go ahead in this case, Dhwani?
you will have to look at it.
Yes. And if vitamin D level is low, as in this case, what will you do?
Correct.
Yes. So we gave a course of vitamin D and the urinary calcium increased. So what it basically means is that this was actually a case of primary hyperparathyroidism. The severity of hypercalcemia and the severity of hypercalciuria was masked because of vitamin D deficiency. This is very, very common in our setting. So before you label anybody as familial benign hypercalcemia, for which nothing much is to be done, you should look at vitamin D level and give a course of vitamin D, and you will get the diagnosis right in that perspective. But then the calcium picked up. No, later on treatment, the calcium picked up on that. 2-year-old girl with abdominal pain, ultrasound showed nephrocalcinosis, calcium is 13.6, phosphorus is 6.2. So what is not likely in this scenario?
The higher side. So, there's should not be the PTH related.
So hyperparathyroidism is unlikely in this case, and you are more likely to be dealing with a vitamin D excess in this scenario. So PTH, of course, was as expected 0, and vitamin D was 200. So this is a very common scenario wherein there is a iatrogenic excess. Parents are giving too much dose of vitamin D, or the doctor has prescribed too much dose. It is usually because of injectable preparations, but sometimes if you continuously take the oral preparation, you will have this scenario, and this is vitamin D toxicity in that regards. 3-year-old boy with bone pain, calcium is 14.4, phosphorus is 4.4. So it's neither here nor there. PTH is undetectable. So this is a PTH independent cause. Your vitamin D is normal, calcitriol is normal. So what are you thinking here?
In the setting of bone pain, one needs to rule out a malignancy here.
So this is an important cause. So very importantly in this scenario, you have to think of a malignancy, and ALL is an important cause of hypercalcemia. You may see a lytic lesion which is causing, and you will find a lymphoblastic leukemia, which we discussed earlier in that regards. A brief overview about management. So what we can do in terms of options is try to take the calcium out from the blood. So what you do here is that you give a saline diuresis. So you give a lot of fluid. You may have double maintenance fluid. You give 40 ml per kg over 4 hours, and double maintenance normal saline. And only after hydration has been achieved, you give furosemide. Very importantly, do not give furosemide if somebody is dehydrated, because that is going to worsen the calcium level. So furosemide as against thiazide, which is retaining the calcium, is promoting calcium excretion. So you expect the calcium excretion to go up, and you will do a saline diuresis in that regards. So you give 0.9% normal saline, 10 to 20 ml per kg per hour, roughly double maintenance. And then after a few hours, you start on furosemide. You expect a decrease in calcium levels by 3 to 4 milligram per DL in that regards. In refractory cases, you may give prednisolone, which will decrease the conversion of 25-hydroxy to 125-hydroxy. So definitely this is a treatment of choice of vitamin D excess. In that scenario, you can use it. Then you can use other agents like calcitonin, but as I discussed, calcitonin is a minor player. It has a risk of tachyphylaxis. So this is something you can use for that perspective. You can decrease the bone resorption using bisphosphonate or denosumab, which is again a rank ligand inhibitor in this regards. And you can use a calcium mimetic like cinacalcet, which is going to work on the calcium sensing receptor, decreasing the PTH effect. So the major acute management is saline diuresis, followed by, if required, you can use bisphosphonates, especially if the renal functions are intact. You may also consider using steroids as a course, and cinacalcet can also be something which is used in that perspective. And finally, if you have a large lesion, you have to go ahead with surgery. So acute treatment is double maintenance fluid up to 3 liter per meter square, and furosemide, and you expect a decrease by 1 to 2. You give furosemide an additional 1 to 2, so around 2 to 4, you may decrease in the first day with these sort of treatments. You can use pamidronate or zoledronic acid as an agent. Pamidronate is preferred because it's a shorter acting one, so you will not have a very long effect in that perspective. And cinacalcet, which is available as an oral medicine, can be used in cases of hyperparathyroidism or a calcium sensing receptor defect. Calcitonin is available as a injectable preparation or an inhaled preparation. The risk is that this is a transient, and tachyphylaxis will develop soon. The specific management includes cinacalcet and surgery for hyperparathyroidism. In fat necrosis, you will use prednisolone and bisphosphonate. So prednisolone will really affect in terms of decreasing the 1-alpha hydroxylase action. Vitamin B toxicity typically will give a course of 4 to 6 weeks of 1 to 2 milligram per kg of steroids. For granulomatous disease, again, like sarcoidosis, is that you should suspect hypercalcemia in a child who's acutely sick, particularly if there's dehydration, constipation, abdominal pain, hypertension. Get a calcium level done. If your calcium levels is high, always check PTH levels simultaneously. If your calcium is high and PTH is about 20, it is hyperparathyroidism. Start working in that regard. Look for urinary calcium. to differentiate familial benign hypercalcemia from hyperparathyroidism. If your PTH level is under 20, look for vitamin D levels. If they are high, it's usually iatrogenic. If vitamin D is normal, look for calcitriol. That will indicate more towards the possibility of granulomatous disease or increased conversion. If both PTH, vitamin D and calcitriol, they are all normal, think of an increased bone resorption scenario like immobilization, hypophosphatemia, malignancy in that setting. So identification of hypercalcemia is very, very important. At this point of time, I'd like to thank all of you for patient hearing, and all of you can go and have a look at our website, learning.society.in, with validated courses related to pediatric endocrinology.